We will talk about the classification, we will talk about the clinical presentation, on how to differentiate it from the organic causes of feeding difficulties. I will show you the latest data. Then we will talk about the treatment approach, and I will present you also my two cases, typical cases, so not unique, and they are not made up. They are real children that presented within the last year. So first, to start with just reminding you that feeding is really a technique that requires an infant to achieve a healthy feeding. It really needs a successful integration of various biophysical functions, neuromotor, physical, sensoric, but it is one end of this whole happening, of this whole miracle actually. It also needs a normal psychomotor development, and what is most important, a normal interpersonal relationship development. In utero, the child, everything gets through the umbilical cord. Once the child is born, suddenly, within days, the infant needs to provide a clear who, to show a hunger. When the child is hungry, when the infant is hungry, as most of you know, cries in a different way than, for example, when it's unsatisfied, stressed for other reasons, and so on. So not only that the child needs to know how to communicate the hunger, but also the person, mostly mother, taking care about the child needs to recognize this as a hunger signal. So to signal the hunger, then within a couple of months to master various techniques, which are not that easy. Breastfeeding, preferably continue breastfeeding, but infants are often transferred to the bottle. It has to master a completely different technique. Then, within a few months, to master a spoon, different textures, different tastes. If I ask you, the child is born with inherited appreciation of two different tastes. Which one? Sweet and salty. That's something that we are born with. We prefer sweet and salty. And it's the evolution has done it. We needed to look for the energy-dense food and also for salt. Previously, there was no salt lying around in supermarkets. And with a natural taste against bitter and sour. Bitter and sour are, for example, poisons. So if you think what type of food is bitter, vegetables, cauliflower is bitter, broccoli is bitter, and therefore in a normal development, the child needs time to accept other tastes and to master all this, and finally to master a self-feeding technique. And all of this can be achieved only through the successful communication with the parents or the caregivers. So in a developmental transition from this into this needs a normal development, needs a normal parent as well. And as you know, there are often difficulties between the transition from one into the other stage, and we will talk about it. Terminology is not very easy. There are different coins used for it, such as picky eaters, food neophobia, feeding disorders, and there are various stages of it, and I will try to show you it through the current international classification diseases. So the last one, the version 2010 by the World Health Organization for the primary feeding disorders says that it's a difficulty in feeding involving food refusal in the presence of adequate food supply, competent carer, and absence of organic disease. Most common feeding disorders, but not primary in infancy, are pica and ruminatio, and we will not talk about this. We will talk about other primary feeding difficulties and disorders. In adolescents, it is anorexia nervosa and bulimia. Do you have a lot of adolescents with anorexia nervosa seen here in Egypt? Not yet. You will get there, you know. So certainly it's increasing, for example, in my country, even boys get those disorders, although females really do the majority of it. Picky eating, no standardized definition, and the meaning changes with child's age. Food neophobia is something that's a normal transition. Children difficult in accepting different tastes within the first year of age. So I would say it is most commonly normal reluctance to eat new foods. And you just have to reassure the parents, and we will talk about it later. Why? So we could see this as difficulties, but feeding disorder is an illness. It is more difficult condition, causing impaired growth, and there are standardized and defined conditions under this, and I'm going to talk about it. When we take all of it, the prevalence, as was already pointed in the introduction, every second mother thinks her child has a feeding difficulty. About just 1 to 2% of them really the child is a serious difficulty associated with the poor growth, so we call it a feeding disorder. 80% of all developmentally impaired children have a feeding disorder, and if we look at it as a whole, then 80% of all feeding difficulties is actually non-organic. Studies, a cross-sectional American study, looking how common it is in the United States. It has been done by an interview. At the age of the child of 2 years, every second mother thought that her child has a feeding difficulty. And you may say it's in the States like that. But I have picked for you completely other part of the world, very, very recently published study. Singapore, also every second mother or grandparent thinks that the child has a picky eating difficulty, and moreover, look here, half of them are very much concerned with this, so it is a significant problem, and they say it has a negative family impact. So you are dealing here with a real problem. With the children, some of them a minority not growing, but however, family considering it as a big problem, so you have to educate the family. Disorders as such, so I'm not now covering the difficulty, but the disorder. The best definition is the one of the American psychiatric disorder. It's well known as DSM number 4, and it says, it's persistent failure to eat sufficiently for at least 1 month. The child stops gaining weight, or it already started losing weight. It's not caused by any other gastrointestinal disorder, any other organic disorder, psychiatric disorder, and it develops in the presence of the food and within the first 6 years of age. And already they have defined 6 different feeding disorders, and I will quickly go over them, and you will easily recognize your patients in it. The first one to develop is so-called disorder of the state regulation. It sounds very, very wise. However, it is the inability of the infant, of the newborn baby, within the first 1 or 2 months, to achieve a normal, calm status, so that the baby is able to receive a milk either on breast or on bottle. So what is the typical clinical picture? The baby starts sucking and then leaves the bottle or the breast and starts crying, being annoyed, too stressed to finish the meal or too sleepy to finish the meal. It says that it is I wouldn't say a defect. It's a slower transition and achieving this mastering in achieving, a wakefulness and differentiate from being sleepy. However, sometimes it goes on and on. It often is mistaken for infantile colics. So it's either too sleepy or too agitated. Mother cannot feed the child, is often stressed and depressed because feels insufficient, and therefore how to approach: first, support the mother. Teach the mother to try to feed the child in as calm atmosphere as possible. Diminish all the possible stressful events, noise, and be in a, let's say, semi-dark room and try to feed the kid to achieve this state that the child can finish the meal, or if the child starts sleeping, gentle massage and then put to the breast again. However, this is a difficulty, but this difficulty can become a disorder and the child is not gaining weight, and only in these cases, while by your advice you could not achieve the child gaining weight, I recommend putting down the nasogastric tube. This is always a last resort in behavioral disorder, because you may even push it further. The second one, if I will tell you primary failure to thrive, what it will learn at the university under the primary failure to thrive, when the infant is not thriving primarily? Defect in the reciprocity between the mother and the child. So the mother is not interested, the child does not feel this interpersonal relationship. So the best diagnostic procedure, how to show that this is really the disordered caregiver-infant reciprocity, is to admit the child to the hospital. Any normal infant in the hospital would stop eating or start crying and being annoyed. This one will start eating. So this is a clear sign that something is wrong in the relationship with the parent. So parents are often unaware, or they do not pay attention, and of course you have to exclude that this is not beginning of autism or any other mental disorder. How to do it? In severe cases, hospitalization until the child is eating sufficiently, the child will start eating. However, the best what you can do is to give to assign one or two nurses that are going to feed the child. Not every shift another, completely other nurse, and next day another nurse. So a single nurse in each shift that will take care about the child. However, whenever possible, do it with the mother. Teach the mother how to feed the child, to sing to the child, to look at the child, to pay attention to it. And only if this is impossible, then the child needs to be hospitalized. Infantile anorexia and the other one, the food aversion, are the most common. We are seeing it most commonly, however, not in the severe forms. So how does it look, an infant with an infantile anorexia? The typical infant, mother brings the child that looks normal, runs around your outpatient clinic, and she says the child is not eating anything, the whole day, not touching or just having one bite and then starts running, and then one bite and then starts running again. So this is called infantile anorexia. The trigger is transition to the complementary feeding, or to another textures, or to another taste. So never hungry, never enough time for a normal meal, too much engaged with the environment. However, and of course you have to exclude organic disease. The child should have a normal psychomotor development. Often this is associated with a sleep disorder, or the mother will tell you that the child has a tantrum spells. You know what are tantrum spells? When it goes down to the line, starts to cry, or doesn't want to. You cannot comfort the child until giving what he wants or she wants. So how to proceed, and we will repeat it again at the end. Meals at a time, restricted time, not the whole day, not the parents running after the child with a spoon, mother, grandmother, you know, showing the TV, PlayStations also. Parents decide on the time, place, and type of the food, but child decides on an amount. That's it, you know. And no sitting on the meal until the plate is empty. 20 minutes, that's it. The food goes away until the next meal, so to allow the child to get hungry. No attention of the left food, no food between the meals. However, this is the normal, something that we call a difficulty. If this difficulty becomes a disorder, and that means that the child is not growing well, and your advice and education is not having a success, then we advise, not we, but it's advised to add seed feeds. Seed feeds means a polymeric pediatric formula which is added not instead of the meal, because you want your child to eat normal family foods, not to eat it before, because you want the child to be hungry before sitting at the table, but to offer it after this 20 minutes and the meal is finished, then offer it to take it if the child is still hungry, you know, and to get extra. To be used after, not instead. The next one, which is very typical, is sensory food awareness. So the parents would come to you saying, oh, of course, he wants to eat biscuits or salami, or, for example, drinks milk the whole day, or as you will see at my case examples, drinks fruit juices, the bottle, sucks the bottle with fruit juices the whole day. So, but doesn't want to eat any vegetables, meat, or cereals, so has a very limited number of foods that is taking regularly. Can cause growth difficulty and or nutrient deficiency, and what to do. In mild cases, just to educate the parents, offer food, do not force feeding, educate the mother that when you are introducing a new stuff, a new taste, that it normally has to be offered 5 to 10 times, sometimes even more, to the child to accept it, particularly with the unfavorable tastes such as vegetables have. So, in case of severe food aversion, exclude the basic food, use only tolerated, slowly introduce new, and use a supplemental seed feeds. The last two are caused by so-called organic cause. The first is trauma. So when we have a post-traumatic feeding disorder, when I say it will remind you, for example, on preterm babies that can often be intubated, ventilated, put a nasogastric tube, so had the trauma to the oropharyngeal this part, and they don't want to eat. Or, for example, had a trauma to the choke. So if they choked with a piece, they may resist feeding, and in that case, the child next day stops feeding, taking fluid, taking normal food, becomes hysteric even on a sight of the food. That's a post-traumatic disorder. Sometimes it can be very severe, requiring a team approach, hospitalization, even the nasogastric tube feeding. Why did I put here a question mark and an exclamation mark? Because by putting down the nasogastric tube, what I'm doing? Again doing the trauma. Again doing the trauma. So it's the last resort for those kids who can, by the normal procedure, and just by giving the supplemental seed feeds, you cannot get them eat. So you need to feed them. This is better to put nasogastric tube than to start parenteral nutrition, but only in the cases where you could not do it any other way. Then the feeding disorder associated with concurrent medical condition. That is something that we fear most. When the child is brought to us with a failure to thrive, we are afraid of missing the organic condition, such as food allergy, severe gastroesophageal reflux, for example, cardiac myopathy, so the big heart, the child is unable to suck, needs the energy, so cannot feed, and failure and has a failure to thrive. So this is something that we have to exclude. Usually the child is hungry, starts feeding, and then stops. It's present for a prolonged time, fails to gain weight, and often there are other symptoms. So this what I have shown to you is this classification, as well as from American Academy of Pediatrics, 0 to 3 years of age. Positive impact of this classification is that for the first time, these primary feeding disorders are classified and described, and we can find it familiar to our patients. However, if you think about your patients, mostly they are a combination. And mostly they are a combination, they don't eat, and they eat just few foods and, you know, not a variety of it. So most of them do not meet criteria, most of them maintain weight, but they have a pathological feeding method and inappropriate food intake, and also within this classification there is a lack of criteria based on which we can differentiate organic causes. If you look at the papers, what are the red flags that we fear, that we need to recognize because they point into the direction of organic cause? It is dysphagia, other signs of the oral motor dysfunction, then weight loss not growing, stops eating due to pain, recurrent or chronic vomiting, diarrhea, blood in the stool, other neuromotor dysfunction, or, for example, psychic disorder, such as I said, is autism, atopy, cardiac diseases, and nutritional support often does not make a difference. So these are the red flags. Why did I underline these two categories? Not because they seem to be most important. However, they are not good discriminators. By definition, primary feeding disorders, the child is not growing and is losing weight. So it is not a good discriminator. And therefore, this is a very good study which I am showing you now. These authors have looked at the big number of children trying with feeding disorder or with failure to thrive due to organic causes, trying to find what is typical for inorganic and what is typical for organic in respect to the behavior of the child, to the behavior of the parents, and to the triggers. And according to the study, look here, selective food refusal, either bottle or spoon or solids, good discriminators, turning the head, shouting the mouth, retaining food within the mouth, anticipatory gagging. It means when the child sees the food starts gagging, or when there is a spoon coming towards him, starts gagging. Lack of hunger cues, why? Good discriminators, but low intake, vomiting, poor weight gain, not a good discriminator. What is the typical behavior of the parent that is a good discriminator? Or she looks normal, and then she will tell you, yes, but when my boy gets sleepy, then I push bottle into it. Or, yes, of course he is okay because I'm running the whole day after the child with a meal. Or he's having a PlayStation and looking at the PlayStation, being distracted, and then she puts food into him. So it's forced feeding, persecutory feeding, conditional destruction, mechanistic feeding, has to stay with the bottle or with the plate until a certain amount is food, and prolonged meals. So this is the typical parental caregiver feeding practice, showing that this is not an organic cause, but it's actually a non-organic feeding disorder. And there are typical triggers to leading to primary feeding disorder. I already said it's transition, It's mechanistic feeding, while we can also have an organic disease, and post-traumatic, of course, they are more common here. So to summarize, poor food intake, poor weight gain, vomiting are not good discriminators. They are present in organic disease and also in more severe primary feeding disorder. Good discriminators is a typical infant behavior, abnormal parenteral feeding practice, and onset after a specific trigger, which I have already mentioned. Here, the study showing, published in Pediatrics, showing what is this behavior, feeding behavior, more common in children with feeding difficulties in comparison to all children. Look here, these are the primary feeding difficulty. Eats limited variety of food, prefers drinks, slow feeder, uninterested in food. So this is, according also to this study, a typical behavior. Our most important question is, does it really matter if the otherwise healthy child is a difficult picky eater, not a simple picky eater, not a child when you will see that the child is healthy, well-nourished and so on, and it's the maternal idea that he is not having enough, but really not growing well. Does it matter? Because it will outgrow of this. So I will show you data which makes us more concerned about it. The first one, cross-sectional study of a population birth cohort done at the age of almost 2.5 years. Out of these almost 500 children, almost 100 of them, parents perceive them as having eating problems, mostly limited variety or preferring drinks. Those 100 of them were significantly more often lighter and shorter compared to those who haven't had a feeding problem. Does it really matter if they are shorter? Well, it matters. For example, this is a good study, not a cross-sectional, a longitudinal study. 2 cohorts compared. 1 cohort, children diagnosed within the first year as infantile anorexia. So no interest, lack of interest in the food and insufficient intake. The other group were children with no physical or psychiatric disease. Those with infantile anorexia, look here, they were seen at 2 years, 5 years, and 7 years of age. At 2 years of age, every second was stunted, and 22% of them were severely stunted. At 5 years of age, 44% stunted, and at 7, certainly 13% moderately or severely stunted. All of you know that stunted children are those who are not growing well, so it's actually not having the height well for weight and for age. Does it really matter if they are not gaining weight, but not growing? Well, there are many studies, and as pediatricians, you are well aware that, you know, when the child is not growing well, it may suffer, you know, in the later in life for various diseases, cardiovascular and so on. But we are mostly concerned of this, whether their psychomotor development will be optimal. I wouldn't say bad, but optimal. So this is a good study connecting growth in early life and IQ at the age of 11 years. So the authors investigated the association between the IQ at the age of 11 years and heights at ages 9 and 13 years. And their conclusions and key messages were that lower height is a predictor of a lower IQ. You will tell me very logically, of course, because children who are not growing are mostly coming from the poor environment, mostly coming from the environment where they lack the stimulation, lack the food, perhaps they are hungry, you know, and therefore they have both of these variables affect. However, if this The lower height was a significant predictor, and it remained significant after adjusting for socioeconomic status, parity, gender, and the birth weight. So the authors concluded that the postnatal growth may have a greater influence on cognition than a fetal growth. There is also a meta-analysis summarizing studies who looked on a further growth, weight gain and height gain in children who during infancy were failing to thrive. And as you can see, those who were failing to thrive in infancy compared to controls later as children, later in life, had lower weight significantly and lower height significantly. The authors of the meta-analysis looked also on the intellectual scores, and as you can see, the difference it favors controls, but it is not significant. If you look, controls the IQ, and those who were failing to thrive as infants' IQ, they are lower, but this difference, although this is on a lower side, is not achieving significant level. Next problem is those who are picky eaters. You will fear of nutritional deficiency, of micronutrient deficiency, which was really shown in this study. So children with feeding problems compared to controls had lower intake of various micronutrients, and for calcium, zinc, and vitamin B6. In this study, this difference was significant. And finally, the last point, those who have feeding disorders as infants tend to be difficult and problematic much later as well. The significant child predictors were the problems started already in infancy, and they already had a lower ability to regulate sleep and mood. They are moody, as I already stressed before. Significant maternal factors were older age, persistent anxiety, and the negative feeling towards the child because of that feeding difficulty. So, obviously, when the difficulty becomes a disorder, it may have a negative effect. So we need to address it. And there are different levels how to do it. So there are measures, behavioral measures that we need to have towards the child, behavior and educational measures for the parent, physiological skills for retarded children. When you have a child with a cerebral palsy, then certainly you have to teach the mother how to feed the child, because the child is often in that position, in that position, and there is a certain position in which the mother can more successfully feed the child. So this is achieving a physiological skill when it is possible. There are often cases when it's not possible, and then there is indication for the percutaneous endoscopic gastrostomy. And finally, there are nutritional issues. How to provide and when to provide nutritional support. Sorry, oops, what's that? Sorry. Oops, okay. Well, I'm not touching this. I think I'll stand here, but some of you won't see it then. I just want to go, yeah, we do it that way. This is a very nice recommendation of the Canadian Society. Canadian Society, Pediatric Society, has the recommendation for the picky eaters, behavioral, educational measures, what to do with the children and with the parents. And most of it I have already told you, but let's go through it again. Reassure parents, for the great majority of the children, they're normal children, normally developing. You have to reassure the parents that after the first year, the child will not gain 10 kilos, but 2 to 3 kilos per year. And also, that the child, when the child starts walking, has a different horizon. It's not anymore fixed on food and the spoon and a breast, but on the environment. And it's running around, and that's a normal feature, a normal development, and lack of interest in the food is something that is normal for the great majority of them. Parents, again, are responsible to choose food. Child decides how much. Small portions, no grazing during the day, no bribes, threats, punishments, limited time for meals, distraction at the table during meals with PlayStations and mobiles not permitted. Meals, whenever possible, should be pleasant, spent together with the family, whenever possible, often impossible, but whenever possible. And when the child is growing well, no need for the appetite, stimulants, or any special measure. However, we already addressed that 100% of children are not growing well. So what to do in these children, in these kids? Is it going? Or it's not? Okay. So in them, it's a time to think about the nutritional support. And this is a pyramid of the nutritional support. Of course, at the top of the pyramid, reserved for parenteral nutrition, is inappropriate for primary feeding disorders. It's inappropriate. Those children have a good gut. Whenever a patient has a gut, we have to use it, because parenteral nutrition is not only more expensive, but connected with severe complications. So, start with the base of the pyramid, should increase in a stepwise manner in respect to the severity of the underlying condition. So the first one is to teach the parents behavioral and educational methods and how to choose the more energy and nutrients-dense food, and teach the children to eat it really. If this is the simplest, the cheapest, and the safest nutritional support. If not enough, then it is a time to provide an oral nutritional supplement. We know it under the coin of SIP feeds. When it is said a SIP feed, it's usually meant a normal polymeric pediatric formula. When I say a polymeric, it means that, for example, nitrogen is coming from the whole protein. So when we have the whole nutrients and they are not pre-digested. This type of the formula is the cheapest. If you go for hydrolyzed semi or totally, the price goes sky high. So this is the polymeric pediatric formula, nicely flavored. It has to be pediatric until the age of 10 years. If you are coming from the poor neighborhood, pediatric formulas are more expensive, then you will start adult formula, let's say, from the age of 8, but no below of it, if possible. In children with feeding difficulties, it is specific that we will never provide a formula instead of the meal, or just before the meal. Because as I said, preferably you want the child to eat the family meal. And SIP feeds is there to substitute for the lack, because we have a feeding disorder. Enteral nutrition, so the next stage in a pyramid, is indicated when the child is you have provided the dietetic advice, you have provided the supplement in a child with a functional gut, but the child is not growing, so it's a time to put down a nasogastric tube. Or in a disabled child, if the parents are spending many hours per day trying to feed the children. As you know, those mothers are very keen. They think that they show their love by trying the whole day to push food in a child with a neuromotor disability. In conclusion, so primary feeding difficulties are very common. Most of them are benign and transitory, and for you is to decide which of them are healthy, not requiring any special. Just reassure parents.
source of milk in the first year, okay? But when you come to if you look to all formulas, they are all derived from cow's milk, so it's not a matter of cow, it's a matter of modification of this cow's milk. During the processing, when you add it, like Professor said, when you add it to fruit or process it, even in yogurt, okay, then it's not prohibited by most, if not all, medical bodies nowadays. So the Estrogen does not prohibit this. The American Academy does not. The European Society of Allergy and Clinical Immunology does not. So the concept now that you can use this, as the professor said.
We have a question. Yes.
Dr. Happy?
Yes.
No. What about postponing the whole cow's milk till the end of the second year? Because do you recommend formula for the baby or not breastfed?
Just to be clear, postponing cow's milk as a main milk,
yes, till the second year, not the first year.
Well, we don't have recommendations considering that. I know that now on the market we have toddler formula, and so on. So there are no clear recommendations saying that cow's milk after the first year, in the second year, is forbidden.
Dr. Happy?
We may think about it, we may think that, but it's not forbidden. It's not yet confusing. You may think that if you have children who have nutritional deficiencies, you would like to give them another formula. But milk is not forbidden. In the second year, milk is not forbidden as a primary milk. What do you think? Do you think that the formula is preferable? Because we don't, I'm not sure, I don't know, because I have not seen any good randomized cohort study randomizing children on formula, on toddler formula versus milk to show the outcome. So we don't have a good randomized studies yet, and therefore we don't have a recommendations. We have our personal opinion, but we don't have a recommendation.
Thank you. Just add a comment. Okay, American Academy of Pediatrics in February 2013, I think, published an article titled "Early Introduction to some cow's milk product like yogurt at the age of 7-9 months reduce the incidence of allergic reactions."
Yes. Not only milk, but also if you introduce fish, it reduces later. If you introduce egg, it reduces later. And it's valid, as you said, for healthy and for those who have atopic predisposition.
First, thank you for this delicious lecture. Okay, one of the things I think you miss here in Egypt, we face over concern of the mothers. When you face a mother proclaiming that their child is 6 years, 30-something kilograms, is not eating well. It's a major problem here in Egypt. Okay, how could you manage two problems? Okay, those selective eaters, I mean those who select some foods. Second, how can you manage children, toddlers, okay, vomit everything apart from mashed food. Otherwise, they are very healthy, well-being, no organic pathology, even endoscopy with normal caliber of esophagus.
Yeah, both can be transitory and both can be very difficult, Those who are drinking only milk or fruit juices, and that doesn't want other food, there is no other way, if they are growing well, to offer them again and again different foods, again and again. So the education, as Canadian society said, offer them at the table not what they prefer, but what you think they should have. If they don't want it, they don't want it. Then try it again tomorrow and the day after tomorrow. That's the classical recommendation.
If you continue over weeks or months.
But those cases are very rare. Mostly they achieve. If they are not receiving it and it interferes with the normal growth, then we use a supplement, then we use a seed feeds, that I'm sure that the child will receive all the micronutrients in that cases.
Second problem, vomiting and otherwise healthy or well.
Yes.
apart from
That's
mashed food,
even more terrible.
Yeah.
That's even more terrible. You know, when they are vomiting and when the parents are mixing the food even with 3 or 4 years of age. There is a physiological, that's a very good point, you know, there is a physiological period in the development of the child, this window of opportunity for achieving texture control, you know, is between 5 and 9 months of age. At that time period, the child is responsible, you know, you can easily introduce various tastes and various textures. If you have not introduced it within it, but you know, mothers were meshing it and mixing it for the whole first year, later it's very difficult to get it. So my only way how to do it is to try and try and try, you know, small pieces, small, bigger, 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 and if you know they're not growing well, again 6 feet after the meal, but in the meal pieces are becoming bigger and bigger. That's the only way, but it's very difficult, you know.
You know, you touched a very important part, because that's the difference between Irene Chatour's classification and Benny Kirshner's classification.
Yeah.
They both work in Washington, D.C. Irene Chatour is one of the most famous legends in the feeding difficulties, and she had a very tough classification, probably because she's a psychiatrist and a pediatrician. But Benny is a pediatrician only, and he modified Chatour's classification and he added the one that you have been asking about, the parents' misconception, because according to Benny, there are 7 phenotypes, not 6. And he focused also on the highly selective. There are some approaches for this highly selective who insist about certain food, the systematic chaining of food and the hunger prompts, and you see, but you, as if you are reading Benny's idea when he started to modify Chatour's classification. Dr. Atif.
You need a microphone there.
First of all, I'd like to thank you for the very interesting lecture. I'd like to ask you about disorders of state regulation. How can I differentiate between them and the physiological infantile colic?
Sorry, I didn't understand.
Disorders of state regulation.
State regulation.
How can I make differentiation between it and the physiological infantile colic?
Physiological infantile colics, children are always eating normally. So when you ask the mother with infantile colic if they eat normally, feed normally, they mostly feed normally, you know. And it starts in the evening, you're all well aware of it. It will start in the evening and so on, but during the day they eat normally and they grow normally. And disorder, it's a disorder, so the child is not eating enough. Because of that disorder, the child is not eating enough. Infantile colic, they eat enough. They grow well, you know, they look well.
Any more questions?